Thank you, Dr. Coe. We're very honored to have been selected as a success story for this momentous occasion of oral health being highlighted as a leading health indicator. We hope our story demonstrates how important oral health is to overall health and well-being, and the role of partnerships in engaging stakeholders to recognize a sense of urgency and to act decisively once a tragedy strikes. Next slide. This slide says so much, but drill down, it really shows that dental caries is a foremost chronic disease in children and far more prevalent than other more well-known diseases and maladies of childhood. Next slide, please. It's often easier to describe oral disease by seeing it. A picture tells 1,000 stories. Next slide. Given the fact that oral disease can have such an impact on a child's overall development potential, it is still alarming about how many children we find in Maryland, one of the wealthiest states in the country, with dental caries, and that a relatively small proportion of them are receiving a proven oral disease prevention strategy in dental sealants. And as is often the case with oral health, low-income Maryland populations are disproportionately affected with a maldistribution of dental practitioners to provide services to them. Maryland has geographic and population-based dental health profession shortage areas statewide. Next slide, please. Of course, the tragic event was the death of a 12-year-old Maryland child, Deamonte driver, due to an untreated dental infection. Although we know of deaths of a similar nature elsewhere, this story resonated because of its proximity to Washington, D.C. and our state's federal legislators. It has been widely reported that Deamonte lacked access to dental treatment services. But equally important is the fact that this child, due to his low-income situation, also lacked access to needed education and prevention services that might have helped avert his need for treatment in the first place. Next slide, please. John Colmers, our Maryland Health Secretary at that time, responded almost immediately, and within months convened a Dental Action Committee to develop a series of recommendations to improve oral health access in Maryland. The DAC consisted of about 26 organizations representing government, professional, medical, dental organizations, advocacy groups, insurance companies, and family support groups. A report was developed within 3 months, resulting in 7 main recommendations spanning many significant reforms. And as you can see, all were approved and many of them enacted within less than a year, receiving state funding through Governor Martin O'Malley's budget, and receiving federal and state legislative support was key. But what's most important here was that many of the partners who participated on the DAC had already been working together for years prior to Deamonte's death on plans and activities to improve the oral health access situation in Maryland. When the DAC eventually met and deliberated, the plans flowed out, and passage of all the recommendations occurred with minor opposition. Next slide, please. Probably the most significant of the reforms dealt with changes in our Medicaid dental program, which previously was part of a system that contracted with multiple managed care organizations. The new dental Medicaid program, now renamed Maryland Healthy Smiles, was carved out of the system and contracted with a single Medicaid dental vendor. Another and obviously important Medicaid reform was increasing many procedures to the median fee charged by local dentists as established by the American Dental Association. Other initiatives included expanding the dental public health safety net system, creating a new workforce category and utilizing public health dental hygienists, and piloting a dental screening program in schools that entails case management and care coordination. Next slide, please. Other initiatives included, in partnership with our state oral health coalition, developing an oral health literacy campaign called Healthy Teeth, Healthy Kids, which targeted low-income families of children ages 0 to 6 and pregnant women. The purpose of this media campaign was to inform this population about the importance of oral health and to empower behavior change with regard to home prevention activities and the need to seek professional oral health services. A website, healthyteethhealthykids.org, and a hotline were also developed. Also, in partnership with our Medicaid program, we instituted a statewide program, Maryland Mouths Matter, that provides Medicaid reimbursement for fluoride varnish application by medical providers during well child visits for young children, so long as they completed our own training program, which gives them guidance in risk assessment, anticipatory guidance, prevention, and referral to dentists. And finally, we partnered with the University of Maryland Dental School to provide training in pediatric dentistry to general dentists in order that they feel more compelled to treat very young children. Next slide, please. You can see the outcomes from these reforms. Considerably higher access for Medicaid children, greater participation by dentists in the Medicaid dental program, and a higher number of fluoride varnish applications to Medicaid kids from trained medical providers. For this, we thank our Medicaid program for all their efforts. We also have now an expanded oral health safety net system, and we recently completed our Healthy Teeth, Healthy Kids social marketing campaign. We're currently evaluating this campaign and hope to extend it. Next slide, please. Partnerships were key to our success in Maryland. We value and have great partnerships with both our state dental and dental hygiene associations, which is critical. But you cannot discount all the work done prior to the DAC to develop partnerships and spread the gospel of oral health when the state ranked among the lowest in access in the country. The partnership started with the traditional dental circles, but eventually spread to groups that we quite frankly didn't know existed and did not know had a vested interest in oral health. In time, we found both federal and state legislative champions through countless visits with them. Everyone was primed and motivated to do something when this tragedy occurred, and to do something more than had been previously done. The DAC did not spend very much time, if at all, on discussing the problems since everyone knew what they were. It immediately went into developing solutions. This was not about individual agendas, but rather the big picture of improving oral health. It was very important to have the dental and medical societies as well as government on board with these proposals, but I think it was equally important that they were exposed to some of the issues that the advocates and parent groups brought to the table. A real trust between everyone ensued, and as the success of the DAC and its recommendations became known, the collective group developed a sense of pride about itself. And with this trust and credibility and good tidings came all the benefits that come with it: pooled political capital, partnership in developing new policies, access to new and expanded networks, and a sense of urgency and empowerment to solve a common problem. This led to the metamorphosis of this committee into an independent statewide coalition. Next slide, please. These strong, successful partnerships allowed the old DAC to make a smooth transition into the independent Maryland Dental Action Coalition, or MDAC. The MDAC developed early success by finding common ground and bringing stakeholders together to support cross-cutting legislation and policies. In short time, it became the main independent voice for Maryland stakeholders on oral health. And as you can see, the Office of Oral Health collaborated closely with the MDAC on the Oral Health Literacy Campaign, the co-sponsorship for a statewide oral health summit, and the development of the Maryland State Oral Health Plan to bring DAC recommendations to fruition. While important that it established early successes to gain credibility, hopefully when controversial issues emerge in the future, the MDAC will be better prepared and certainly have the confidence to deal with it. Jane Casper is here representing the MDAC, and I'm sure can answer any questions regarding further details about it. Next slide, please. Maryland did receive some national accolades and attention from our federal and national partners, which is always appreciated since it makes it easier to get support locally, but much more needs to be done. There are many great state oral health programs out there, and we know that state oral health programs in every state can play an important role and need to be supported so they can, in turn, better support oral health as a leading health indicator. Next slide, please. Here's just a short list of where we still need to go in the future. Primary is implementation of the State Oral Health Plan, which encompasses many of the items that you see on the list. And next slide, please. And finally, this slide kind of speaks for itself. This is what happens when I speak to my sons. So thanks for your attention, and hopefully you didn't have the same reaction. Thank you.